You're live.
Assalamu alaikum and good afternoon, dear participants. Welcome you again. This is 66th session of our lecture series, and today's our topic is normal ECG variants in adults. We have two respected discussants today. The first one is Dr. Swadesh Chakraborty. He is Assistant Professor, Department of Cardiology in Shohid Sheikh Abu Nasser Specialized Hospital, Khulna. And our next discussant is Dr. Abu Muhammad Shafiq, is Consultant Cardiology, United Hospital. Before start of the session, I'd like to request Professor M. Atar Ali sir to say some words regarding our discussions. Atar Ali sir.
Thank you, Dr. Tushar. Good evening, everybody, and dear participants, and particularly our honorable faculties and course director Rafiq Ahmed sir is with us, and also we have got Dr. Naharuma Kanis Fatima. Welcome, everybody. Sir, there are two speakers today, sir, Dr. Swadesh Kumar Chakraborty and Dr. A.M. Shafiq. I want to introduce Dr. Swadesh Chakraborty. Sir, Dr. Swadesh Chakraborty is practically our student. He is now working as assistant professor in Shohid Sheikh Abu Nasser Specialized Hospital, Khulna. He is a very young cardiologist. He passed his MBBS in 1999 and completed his MD cardiology 2010. After that, he got training in interventional cardiology in Escorts Hospital, New Delhi. He is a very dynamic young interventional cardiologist. He is a good teacher and is a super clinician. Dr. Swadesh Chakraborty is a very difficult topics today, Dr. Swadesh Chakraborty. We want to enjoy your topics. And Swadesh Chakraborty follow Dr. A.M. Shafiq, sir. A.M. Shafiq is a very dynamic interventional cardiologist, a clinician, teacher, and he loved to teach ECG to his all young fellows. Dr. A.M. Shafiq is a very special person. We like him. So throughout the session, we are happy that Dr. Rafiq Ahmed sir is with us. So very difficult topics today, and I want to enjoy your topics with the help of Dr. Rafiq Ahmed sir. Dr. Swadesh Chakraborty, you can start your topics.
Thank you, sir, for your kind words. Actually, I was student and I like to be student of teacher like you. And today, respected course founder course director Professor M. Atar Ali sir, international course director Rafiq Ahmed sir, and learned participants, very good evening and welcome you all to this academic session. Actually, I feel honored and lucky enough. I am grateful to ECG study group to giving me the opportunity to discuss in this very academic platform. I am sharing my screen. I'm working. So check Abu Nasser Specialized Hospital. Shoaib Abu Nasser Specialized Hospital is situated in Khulna and providing several specialized service under the single roof. It is, am I visible, sir?
Yes, Swadesh.
It is the view of Shoaib Abu Nasser Specialized Hospital. Now I'm going to my topic. Is the normal variant. What actually we mean by variant? Variant is a noun and a form of version of something that differs in some respect from other form of the same things or from the standard. According to Cambridge English Dictionary, meaning of variant, something that is slightly different from other similar things. In ECG, the variant is electrocardiographic pattern which appears to be abnormal yet occur in healthy individuals without any heart disease are termed as normal variant. In other words, in contrast to pathologic ECG patterns of normal variants can be described as constant ECG patterns that are neither linked to the corresponding typical symptoms, nor to corresponding clinical and anamnestic findings, and not to drugs. Certain recognized factors such as position of the electrodes on the chest are known to cause variations in ECG. Detection of normal variants are important, and some normal variants are easily recognizable at a glance, have distinct patterns, have been designated by specific terms. Other may be less specific and affect mainly the TOA. Variants can be divided in children and other forms in adults. Our today's topic of interest in adults. Now we'll discuss few ECG variants. You see, there is two ECG. The upper one, the heart rate is around 50, and in the lower one, the heart rate is around 115. So it is sinus bradycardia and sinus tachycardia. Can it be a normal variant? Sinus bradycardia is often seen as a normal variant in individuals at rest and usually in athletes. Episodes of sinus bradycardia at a rate of even less than 40 beats per minute can be observed in young healthy people, sometimes with sinus pauses of up to 2 seconds. Sinus tachycardia is normal during exercise and under conditions of mental stress. And look at the rhythm of this ECG. The lower part, there is the rhythm strip, and initially the heart rate is around 75, and in the middle part the heart rate is around 100. So RR interval varies from phase to phase. So it is in types of arrhythmia. Generally, sinus rhythm is not completely regular, especially in lower rates. If the deviation exceeds more than 15% of the basic rate, the term sinus arrhythmia is used. In young healthy people, the rate variability may exceed 50%. Sinus arrhythmia is almost always normal. Now come to the P wave. In this ECG, you see the P rate in lead 2, 3, AVA, and some of the chest leads. So there we can see the P wave vector. It is the fusion of the left atrial vector and the right atrial vector. And we found different forms of P waves in different leads, and in AVR it is inverted. In AVL it may be biphasic, and in most other leads it is usually positive. The P wave vector in sinus rhythm is a fusion of right atrial vector and the left atrial vector. In the limb leads, the fusion vector that corresponds to the P wave has an axis of plus 50 to 80 degree, often around 70 degree. As a consequence, the P wave is always positive in lead 1 and always negative in lead AVR. The P wave is mostly positive in lead 2, AVF, and 3, but may be biphasic in these leads. In leads AVL, the P wave may be biphasic, positive, or even negative. There is no real differential diagnosis of sinus rhythm. Only a rare focus near the sinus node cannot be distinguished from one of the sinusal origin. In this ECG, probably it is a lower atrial rhythm. And now come to PR interval.
Swadesh,
Sir,
Swadesh, can I interrupt you?
Sir.
Can you go back to the previous ECG?
Sir.
Previous ECG.
Sir, this one, sir, POF.
This one. Sir, Rubik, sir. Sir. Now I want to comment from Rufik Ahmed, sir. So we'll discuss this ECG afterwards, Shajesh.
Sir, sir. Sir, now PR interval. Normal PR interval is 0.13 to 0.20 seconds. There are AV blocks in normal individuals. First degree AV block may occur in about 10% healthy young adults. Intermittent second degree AV block, Wenckebach type, is about 5%, especially in athletes and during the night. Early atrial premature beats may be completely AV blocked in normal individuals, especially in persons with first degree AV block and during bradycardia. And you see, now we are going to discuss about the QRS complex. In this ECG, you see the QRS.
We should do that.
QRS is the axis, frontal plane axis. We usually assess the frontal plane axis from the limb leads. In this ECG, the axis is around plus 80 degree. That is, it is near the right side. And in this, the axis is around -10 or 20 degree. It is a bit shifted to the left. So what is the normal? What is the normal QRS frontal plane axis? It is very variable and uniform in horizontal plane. The frontal leads, the direction of QRS vector depends on habitus, body weight, body position, and age, and many unknown causes. Generally, the mean QRS axis undergoes a rotation from right to left during aging. Right axis deviation or left axis deviation are rare in middle-aged patients, and substantial changes of frontal plane QRS axis within a short needs further evaluation. This is the changes that occurs from younger age group to older, the axis of frontal plane, and come to horizontal axis. And lead V3, the R wave is still smaller than the S wave, and lead V4, the amplitude of R wave is greater than that of the S, sometimes with a small Q wave. And now see these two ECGs. First one, you see the R wave is greater than the S wave in lead V2. And in the lower ECG, you see the R wave is greater than the S wave in lead V6. So in first one, the frontal plane axis is shifted toward the right. And the second one, the frontal plane axis is shifted toward the left. So this shifting is also called the clockwise rotation. The transition zone from negative to positive QRS shifted to the left. This condition is also called poor progression of R wave in the precordial leads. And counterclockwise rotation, the characterized by shift of the transition zone to the right. It is more common in young healthy individuals and children. In some cases, clockwise or counterclockwise rotation may be caused by erroneous placement of the precordial leads by one interstitial space too low or one space too high, respectively. Now see the Q wave in lead V3, small Q wave in lead V3, and here in this ECG, Q wave in V1 and V2. So this QS or QR pattern in lead 3 is found in some normal and in various pathological conditions. A QS pattern in lead V1 or V2 found in healthy hearts is a normal variant or is due to misplacement of leads in one interstitial space too high. The correct diagnosis of Q or QS in lead 3 and QS in V1, V2 is met not only by morphologic ECG criteria, but also by anamnestic and clinical findings. In cases of doubt, further examinations and investigations are necessary. You see in this ECG, there is RSR prime in lead V1, V2, V3, and also in lead 3. Here, R R height of R wave is smaller than height of R prime. And this ECG, again RS R prime, but height of R is longer or larger than the height of R prime. So it is incomplete right bundle branch block pattern. An incomplete right bundle branch block pattern is a frequent finding in healthy people, especially in young people. This pattern may lead to notching of RS R prime complex in lead 3 also. Height of R more than R prime, a normal variant is probable. The QRS configuration with height of R smaller than R prime presents a normal variant in many cases. However, we have to exclude disease of the right ventricle. In this ECG, see the V3, the QRS complex a bit white and there is a notch, but QRS complex is still within the normal duration. So this pattern may persist as a normal variant. Sometimes low voltage QRS complex also seen as a normal variant. Now come to ST segment. In this ECG of this young man, you see the ST segment is clearly elevated in lead V2 and V3. J point and ST segment may be elevated up to 2 to 3 millimeter and rarely up to 4 millimeter. Relative high amplitude of the S and T waves in lead V2 and V3. This common pattern of repolarization should not be misinterpreted as acute ischemia. And again in this ECG, you see there is elevated J point and T wave ST segment concavity upward, especially in lead V2 and V3 and also in V4. This example of early repolarization. Early repolarization is characterized by marked constant elevation of the J point and ST segment in 2 to 4 millimeter, emerging directly from R wave downstroke in the anterior tricordial leads and or the inferior leads 3 and AVF. Now come to T wave. In this ECG, there is T wave inversion in lead 3 and many of the chest leads, especially to V4. And in this ECG, T wave 4. So normal T wave is slow upstroke and more. The frontal leads, the T wave is positive in lead 1 and often positive in AVL, lead 2, AVF and 3. The T wave is often negative in lead 3 and AVF occasionally in lead 2, independent of frontal plane QRS axis. In a QRS axis of 0 or less, the T wave may be negative in AVL, but never in lead 1. In horizontal leads, the T wave is negative or positive or isoelectric in V1 and positive in V2 to V6. In some cases, there is a negative T wave in V2, V3, especially in young women up to age of 30 years. Now, see in this ECG, the rhythm, there is supraventricular ectopics. And in this ECG, there is a ventricular ectopics. With QRS inverted T wave, there is a compensatory pause. So this is an example of supraventricular ectopics and ventricular ectopics. Now come to arrhythmias. There is no strict dividing line between pathologic arrhythmia and normal variant arrhythmias. Arrhythmias that occur so frequently in individuals without heart disease may represent normal values. 3 conditions fulfilled: absence of any heart disease, exclusion of many arrhythmias not representing normal variants, and a normal variant arrhythmia should occur only rarely and should not be associated with very low or very high heart rate. However, a healthy individual may feel a normal variant arrhythmia. There is a long list with frequent normal variant arrhythmias. There may be sinus bradycardia, sinus tachycardia, sinus arrhythmia, isolated ventricular pause, some forms of supraventricular ectopics, and also some forms of ventricular ectopics. And these are the list of arrhythmias not representing the normal variants, not going in details. If anybody interested, I will discuss in later. And now comes some conditions associated with well-recognized electrocardiographic variants. Juvenile patterns, hyperventilation and anxiety state, effect of heavy carbohydrate meal, the athlete's heart, and the early repolarization syndrome. The juvenile pattern in adults, T-wave inversion, which is normal in children, in tricordial leads, like V2 to V3 or 4 in a normal adult is called the persistent juvenile pattern. After third decade of life, it is abnormal. And hyperventilation anxiety states may cause sinus tachycardia, prolongation of PR interval, ST segment depression with or without T-wave inversion, especially in inferior leads, may present in a normal person. Effect of heavy carbohydrate meal, ST segment depression and T-wave inversion may be seen without any pathology. And athlete's heart, increased vagal tone and increased ventricular mass may cause this well-recognized variant. There is sinus bradycardia, maybe junctional rhythm, first degree AV block, sinus arrhythmia, Wenckebach second degree AV block, and wandering pacemaker. And increased muscle mass may cause voltage criteria of LVH, increased amplitude of P and T wave, persistence of U wave, increased PR, QRS duration, and slight ST depression and T wave inversion. And early repolarization syndrome, I have already mentioned earlier, but because of early repolarization, as it may occur also in different types of cardiomyopathy, myocarditis, and myocardial ischemia. So be careful about early repolarization. This is the example of early repolarization. Now, some specific ECG abnormalities may present in normal person. These findings are undoubtedly abnormal, but may occur in healthy person. These conditions increases with age, so must be investigated for organic causes. It's frequent premature ventricular contraction, atrial fibrillation, first degree AV block, left axis deviation, left bundle branch block, abnormal T-wave inversion, and WPW syndrome. Now I am the last part of my presentation, and so if we summarize the abnormal normal variants of the ECGs, P-wave variants, there may be abnormally tall P-wave with normal duration, notching of P-wave with normal duration, QRS complex variants, abnormal T-wave for normal duration, tall T-wave in tricordial leads, high voltage in tricordial leads, AV nodal or intraventricular conduction delay, long PR, bundle branch block, notched QRS, and persistent juvenile pattern, early repolarization syndrome, especially below 30 years of age, non-specific T-wave variants, early transition or counterclockwise rotation, or poor progression of the R waves, and ST segment variation like J point and ST segment may be elevated up to 4 mm in tricordial leads, and sinus arrhythmia with supraventricular ectopics and sometimes PVCs. This is the end or last slide. Thank you for your patience.
Dr. Swadesh, can you stop your screen sharing?
Sir.
Thank you, Dr. Swadesh, for your nicely prepared, excellent talk, but very many lots of information. Rofiq Ahmed sir, I like to request to make a summary. It's a very difficult and long but many information, sir, about the. I did not actually. I had no idea about these such kinds of normal variants. Huge information, sir.
No, thank you, Shadesh. Very good lecture. I mean, we have to remember these things. So the ECG is a picture. So what happens is you can go two ways. One is what we consider normal, and then you find something grossly abnormal. And then sometimes you will find a P wave looks funny in lead 2, 3 AVF. Really, it is sinus rhythm, but then you exclude it and then find out that this is actually a variation of normal sinus. But to this thing, I think it will be a very interesting project for anyone to set a standard for LVH in Bangladesh. What the Japanese did is that in Japan, they don't use S1, V5, S1 in V1 and R in V5 more than 3.5. That's the Western standard. They use 4.5 millivolt. So I think with the presence of echo, one can do a study whereby they will take standard readings and compare with the echo finding and come up with sensitivity and specificity. And you can talk to a statistician to find out how many patients you need to do this. This is a very good project. Either Wadud or somebody in academic can give it as a project to a student. And the good thing about this is that in the old days, you have to wait until the patient dies to confirm that there is LVH. You don't have to do it anymore. You can use echo as a standard for this. And that will be a very good project to do. Thank you.
Abdul Chaudhary.
Shadesh, that was very wonderful and very surprising. But you have rightly shown how many variations are there. And it just shows that whatever the finding is, you have to interpret the finding contextually. So in a young girl, teen version in V1, V2, V3 is quite all right, but not so in a young man. That's the context we have to think about. After heavy meal, after emotion, there are T-wave changes that can happen. So these are interesting findings and interesting observations, and the knowledge you have gathered nicely in such a beautiful lecture. Thank you very much. Thank you.
Thank you.
One of the quick note for everybody, if you think that the patient should have a normal ECG and you find V1, V2, V3 abnormal, please recheck the position of the electrode.
Yes.
That is so, I mean, and those leads are it happens always. In our office also, we have technicians, they do it, and they just take it casually and just put it anywhere. So that is the most common mistake site. Limb leads are difficult to misplace. I mean, you can put right and left, but you cannot, if you put you can put it anywhere on the arm, it doesn't matter. But the chest leads are the most difficult ones. Please keep that in mind. Thank you.
Sir, early
I'd like
regulation.
to add something otherwise in
Yes, sure.
context of the Rafik sir's comment. In our country, most of the ECG technicians, they learned to put the V1 in the second space, V1, V2. Why, from where they have learned this, I don't know. And most of the technicians do the same mistake, and all the nurses also have learned this mistake. And that's why often the findings comes like that. And this T inversion is very common in those leads.
And also you end up getting septal MI in those.
Yes, sir.
Because the lead position high, it ends up with Q in V1 and V2.
Yes,
And
sir.
when you see the ECG, you have to report it as septal MI. You cannot deny that.
Yes, sir.
But actually it is not septal MI, it's just lead malposition.
Sir, can I show one of the ECG I have shown?
Yeah,
in the,
yeah, please, please.
Sir, this ECG, you see, there is a QAB in lead V1 and V2. It seems like septal MI. And again, you see the T wave inversion in lead 1, AVL, and V6. Actually, this is an ECG of a patient of left ventricular hypertrophy that I've mentioned Rafiq Ahmed sir a bit earlier. I have done echocardiography of this patient, and it is not a normal variant. Actually, it is left ventricular hypertrophy and erroneous placement of the chest rate, probably 1 space above that have mentioned by Jamil sir.
Most likely,
Thank you.
yes.
Thank you.
Sir, in some ECG reports, sometimes we see that there is advice that the echo is advised. After commenting about this, is it right, sir?
Well, the question is, when you see an EKG and you advise echo, we say clinical correlation needed. We do not go beyond that. We don't advise any test based on ECG finding. It's a clinical judgment. So I don't think that should be written actually. I have never seen it. Nobody ever have asked me that question.
Sir, early repolarization is a very frequent finding. When you should investigate that patient, sir?
So the question is early repolarization. So somebody, young person presents without any chest pain for something totally unrelated. That's number one. Number two, only thing that you can confuse is two things. One is acute MI and pericarditis. And what do they actually have shown it? If you are really curious about it, you can look at the ratio between the T wave and the ST elevation, and that will give some clue. You can compare with old ECG also, and especially in a young person, totally asymptomatic. And that should be those are the reasons that you can say this is early position versus pericarditis or acute ischemia. But also we need to remember that despite all these things, there will be still, we are going to miss or we are going to overdiagnose cases. There's no question. But question is how many? And that is the thing, that how many overdiagnoses we can do, how many underdiagnoses, that should be less than 5% or so, preferably. But anything up to 10% should be acceptable. And in reading ECG, a mistake of 1 or 2% probably is acceptable for all of us, because we read very fast. I mean, at one time I could read up to 200 ECG an hour. That means I am giving probably a little bit over 30 seconds or something for each ECG. But that's a pictorial reading, which means I am actually scanning fast, but then I will stop somewhere as soon as I see the pattern is a little different, and spend some time on that ECG. Thank you.
Sir, sometimes in Holter, there is no complaint and there is no tracing documents, but in the computer's text, there is some comments that there is a few seconds atrial fibrillation like this. And Dr. Swadesh has shown that the atrial fibrillation may be a normal variant sometimes. Sir, what we should do in this case, sir? That is there is no documents in the tracing, but computer has said that there is some few seconds of atrial fibrillation.
Okay. Yeah. So, I mean, I would like to have the tracing. So I have said repeatedly that even if I reported it 5 years ago and you bring it to me, I would like to see the tracings again, because my vision had changed by this time, in good way or bad way, both ways. So tracings are so important. I mean, I would like to, I mean, we get a lot of Holters readings, and anytime there is some arrhythmia in the report, I always tell the technician to print out the page and give it to me. And if need be, magnify it. The only time that you can confuse AFib will be atrial tachycardia with variable block. And that is where the confusion comes most of the time. And let's say if there is somebody with 70-year-old male with history of stroke, hypertension, and diabetes mellitus, you are better off making mistake on the side of AFib. On the other hand, if it is a 15-year-old person with atrial tachycardia with variable block, you are better off making mistake on the side of atrial tachycardia with variable block rather than AFib. And I'm sure the panelists will agree on this thing.
Yeah. Against the context.
Exactly.
Sir, one question is that, sir, sometimes in the Holter, we could see lower heart rate, minimum heart rate is 42.
Yes.
If we look into that particular area, then we could see this is because of the ectopic following gap. So this portion is the heart rate is 42. But still, we used to report, but many reports I could see the comment is minimum heart rate is 42. But is it 42? Sir?
So the question is, the heart rate is 42.
Right.
What we do, our machines actually now give 2 heart rate.
Right, sir.
1 heart rate during sinus rhythm.
Correct, sir.
And then there is a second heart rate category whereby it comes with arrhythmia. So it says minimum heart rate 32, maximum heart rate 169. That means somebody was
Right,
having
sir.
atrial tachycardia. But in
Right,
the sinus rhythm, the heart rate, and that's what is important, I think.
Right, sir.
So nowadays, people are using a lot of pulse oximeter. And in the pulse oximeter, we'll find out the ectopics are not actually registered. So if a patient have bigeminy, and the heart rate will be 40, actually he has a heart rate of 80. And that creates a problem with the patient's family, and everybody become anxious. What I say to the students, you do not look, whenever there is arrhythmia, do not look at the heart rate through the pulse oximeter. Feel it yourself and count it at least for 30 seconds. Then you decide what is the heart rate.
Right. May when I can speak one experience. I was called to see a patient, and they requested me to take the patient to the cath lab to put a temporary pacemaker. I just told her that I am just coming and see the patient, that I'll decide whether I will take the patient to cath lab or not. Then I immediately rushed to the patient, and the pulse oximeter was there, and it shows around 36 to 40 heart rate. And I just felt the pulse, it is almost 90, because patient is in the atrial fibrillation.
Yeah.
Actually,
That was a
one
COVID
should-
patient.
Actually, one should not count the heart rate from the bedside monitor, but it shows 3 or 4 complex make one red. Within few seconds it changes. So one should not count that one, and one should not take from the pulse oximeter. It should be palpated at least 30 minutes, 30 seconds. What would say?
Thank you. Shall we move to Dr. Shafiq?
Yes, sir.
Nahruma, do you want to make a comment? Because you are a pediatrician. What about the normal variations that are present in the children?
So that's a nice question. So always we put ECG a slide that was Shadesh Bhai was showing in the last slide. That what was the normal variant in the neonate, infant, adolescent, and adult. In case of neonate, the axis will be right, but how much right will be accepted as normal? If it is in right lower quadrant, then it is normal. But if it is extreme right axis, then we can put a diagnosis that severe or critical PS, or due to pulmonary atresia or TOF. But in case of TOF or severe critical PS, the axis not will be right axis. But sometimes we have to correlate with clinically. Sorry, sir, I was walking, I was in the stairs, so I was a little bit in
Shortness of breath.
okay, sir. And the axis is important, and it will be in normal axis when the age of 4 to 7 years of age. And in newborn, that I told that it was right axis, and it was in 1 year, it around normal axis, and 3 to 7, it was in like adult. Minus 30 to minus 90, minus 30 to 90. And one thing important that ST elevation, that was initially uprise of ST elevation in initial 48 hours. Then ST will be normal after 48 hours. So this ST elevation also, if we find and we terms level it as pathological, that will also not be, it is normal variant. And Another thing is, sir, we usually that it is almost like that, sir, that axis and the RVH, LVH, all these things, sir.
Thank you. Thank you, Nehma.
Yes, thank you, sir.
One question is there. Swadesh, can you answer that? Dr. Kanish Fatima, she asked, she is assistant professor in Bardem. ST changes due to heavy carbohydrate meal seen in which leads? Is it all the leads or only the inferior leads? Can we answer that, Swadesh?
Sir, actually, this is not so specifically mentioned. One paper I have seen, it is usually in chest leads. STT changes in chest leads. And the explanation they have put, that probably high carbohydrate causes shifting of potassium intracellularly more, and that may cause the STT changes.
So my curiosity is, if one have a very big tummy, is there any changes in the inferior leads?
Sir, body weight, posture, position of the heart, that may change, may make changes the ST or T change.
Atar bhai, should we go now
Yes,
to the next
yes.
stage?
Yes, Dr. Shofik.
So Shafik is going to give us the
Great and beyond. Great and beyond bakery.
That's a good slide.
Thank you, sir. Thank you very much for giving me the opportunity in this forum to show some ECG and to learn myself as well in this forum. And definitely our learned audience will enjoy, inshallah. And definitely I should learn from Rafiq sir, Atar sir, Wadud sir, and Jamil bhai as well. So I just want to show some ECG for discussion, and through which I want to learn so many things. So first, can you see my, just I'm taking things below. Okay. So male 62 years, diabetes, hypertension patient transferred to a hospital emergency department after 2 days of AMI inferior. Got STK in that hospital. Then in the ambulance, during transferring the patient to our hospital, patient experienced chest pain, and at the same time, she had a short period of unconsciousness. In the emergency department, this ECG we could found. Actually, I was not in the emergency department. Just I was have a phone call, patient with chest pain there, and they wanted to take the patient to cath lab. So what could be the diagnosis? Patient already got streptococcus 2 days back for inferior myocardial infarction, and patient came with this ECG. So I just want to get some poll. Could it be acute inferior myocardial infarction with sinus bradycardia with tall T anterior due to hyperkalemia? Acute inferior myocardial infarction with sinus bradycardia with tall T anterior due to hyperacute anterior myocardial infarction? Acute inferior myocardial infarction with 2:1 second degree AV block with tall T due to hyperkalemia? Acute inferior myocardial infarction with 2:1 second degree AV block with tall T due to hyperacute anterior myocardial infarction? Or acute inferior myocardial infarction with complete atrioventricular block with tall T due to hyperacute anterior myocardial infarction? Can we get the full review?
Uh, 30 seconds for the poll. Sir?
Right.
Yes,
Okay.
dear participant, please vote. Vote, please.
Kamal bhai, please give 30 seconds for this.
Yes, 30 seconds. Okay. So maximum B, that is acute inferior MI with sinus bradycardia. Sinus bradycardia with tall T anterior due to hyperacute anterior myocardial infarction. And also CD as well. So if we go back to the ECG again,
Can you, yeah, that's right.
okay. So if we go back again, so this is inferior myocardial infarction, already been told. This is from the history, and patient got streptocarditis, and as well we can see poor R wave in to AVF and Q wave in the late tree. So it is acute inferior myocardial infarction.
Shafiq
But,
bhai.
yes.
Is here.
Oh, Hafiz bhai, I was just waiting for you
Assalamu
because of
alaikum,
the
Hafiz
first
bhai.
slide.
Oh,
Bread and
this
beyond.
is fantastic EKG. First of all, there are two processes. One is the rhythm issue, and the
Right.
other one is the STQRS morphology issue.
Right.
So I think if the participants follow that, then I'm sure you'll go through this rhythm issue first, and then the EKG issue.
Right.
But I would request the audience
Poll is over. Poll is
No,
over.
no, I know poll is over. I was the poll, but this is a good thing that everybody is divided. But I would not feel intimidated by anyone, if we get it right or wrong. But I'm saying that the management wise, one thing you mentioned, that there was a significant event happened to the patient.
Right.
Please take that into consideration when you
Right.
do the management. Yeah.
So
Go ahead.
is there-
Sorry.
Is there any Nepali friends from Nepal?
Do you have an EKG before this with inferior?
Right now, this is not with me. Actually,
Okay.
that was in the single lead ECG. That is why I did not take it here. But that is what inferior myocardial infarction. That was correct. And patient got streptocarditis in Mymensingh. Then patient transferred through ambulance, and then patient developed during the just before entering into the entering Dhaka. The patient was unconscious with chest pain for a short period. Then patient revived.
Because the other question would be that if patient did not have any history, just came in with this EKG in the ER, how would you have approached? That's another question.
Yeah,
It's a fantastic EKG.
that's a very good dilemma.
It is just a few days back in my hospital, just 1 week back. So any other, if there is any other discussion, sir?
I will be asking for a posterior leads.
We did not do the posterior leads, sir.
Shafiq.
So can we make a comment? Because now that you are not giving the diagnosis yet, but
No,
maybe
already, but actually, there are so many options I told.
I go with
I did
C.
not say the diagnosis yet.
Shafiq.
Shafiq, can you go back, please? And Jamil wanted to say something.
Okay.
I go with the diagnosis what put by Shafiq as in the C, and most of the poll participants were against it. Probably few have voted for this C, as because it is 2:1. Every block,
Correct.
PRMI is there, and there is clean cut in the bottom panel in the lead 2. Equidistant P waves are there, and every P wave is not conducted. Every alternate P was not conducted.
I think the
Okay.
Ravi bhai will agree.
Along with this tall peaked T wave indicates this hyperkalemia that is leading to this rhythm problem.
But the point is, you got a tall R wave in V2. That's not expected. And in the context of inferior MI, there's likely to be a posterior MI. And then that T become the inverted T wave of posterior MI. That's another possibility we have to remember.
Maybe.
So before
I
Dr.
would like
Shafiq
to
goes, can I make a comment?
Yeah.
I think Hafiz put it in a very, very nice way. The two issues, one time I have to agree with Hafiz. So at least one time I have to agree. So Hafiz put it in two very nice way, that two issues, that one is the rhythm issue, second issue is the ST segment
Yes,
issue,
sir.
and which
Yes,
is
sir.
more important.
Right, sir.
I think the ST segment issue is more important
Yeah.
than the rhythm issue, because we know the patient. And secondly, why is more important? Because the KYS is narrow, so I feel a little reassured. So if I look at it, I see subtle, but there is clearly ST elevation in lead 2-3 AVF. So if I did not know this
I've got
patient at all,
disconnected,
this
I
was the
think.
first ECG. Chest pain, I would say an acute inferior MI.
Yes, sir.
That will be my first thing. Second issue is that there is a tall T wave. Is it hyperacute or is it hyperkalemia? The base is a little, I mean, I'll keep both in my spectrum, but the base of the T wave is a little wider than what we normally see in hyperkalemia with that kind of T wave. So my first point will be an possible hyperacute. Even hyperacute T wave, of course, you expect the ST segment to become a little flat, which it didn't. It's a little concave.
Right.
So that's why it's confusing. But I will first go with the clinical gut, that clinical scenario, chest pain, acute inferior MI, possible hyperacute T wave. Second will be the rhythm issue. If I look at V4, and if somebody tells me this is sinus bradycardia with a E wave, I have to buy that. However, if I go to lead V1, that changes. So that's why you have to look at multiple leads. So because in V1, the P wave is negative, and you can clearly see there is a 2 P wave, so 2 to 1 heart block. I'm going to stop there and let Dr. Shafiq take over, please.
Thank you,
So
sir.
I
Thank you,
have
sir.
one thing to add, Rafiq bhai. The patient had further chest pain after lytics,
Right.
and then
After 2
patient
days.
also had a bad event. And
Right.
this hyperkalemia can give this thing, but there is acute coronary insufficiency with anterior, with LAD. Sometimes we see that, and it reminds me of D Winter sign. D Winter sign is the little ST change and then very sharp angle, tall peak T. So I'm really worried that this could be another issue with the LAD territory. But I would do the same thing, that will check the potassium and kidney function, but I would have a very low threshold to take to the cath lab, not to wait.
Okay,
Right,
Dr.
sir.
Shafiq. Okay, let's
Yeah.
see.
Okay, sir. Actually, a patient came to the cath lab directly. I told them to take the patient to the cath lab, and I was in the cath lab. And I got the ECG, and just I had the initial diagnosis, something what told Dr. Jamil Bhai. This could be hyperacute T because of hyperkalemia. And let's do a ABG first to see the potassium level. And I could get the potassium level 4.5. So never delay, take the patient to the cath lab. So I have taken the patient to the cath lab and did the angiogram. So this is LCX is this is the culprit
I
vessel
see
of
you went from the
inferior
groin. Did you put a venous line or temporary
Yes.
wire? No.
Yes. I have taken the venous line, but I did not put the temporary pacemaker. I did take it as a venous
Smart
line.
move.
Definitely, no doubt, need to be taken. So this is a dominant vessel, and here you could see here there is a thrombus in the ostium of the LAD. Dangerous position. Already MI developed because of the LCX. This is dominant LCX. And this is the previous MI, inferior myocardial infarction. And this time, patient developed thrombus at the ostium of the LAD. And patient's blood pressure is around 90/50 in the cath lab. So what to do? No way to, so we need to treat it. So first we put a stent in the LAD, the LCX, then stent in the LAD to lip main. Erythropoietin. So this is the scenario. And in the table, patient blood pressure goes up to 130/80. And then patient sent to the CCU. Then we did the ECG, and ECG is like this. So after few hours, the ECG is this, and patient really it is.
It's like sinus now.
It is sinus now, and actually sinus develop when we put the where then patient did the sinus, and that is why we did not put the temporary pacemaker there. But the patient developed cardiac arrest after reaching to CCU, and then when the ejection fraction was only 30%, and immediately patient developed bradycardia. Later on, patient was given atropine. That time, patient developed tachycardia and gone into failure. Then they ventilated and resuscitated, and later on, patient extubated, and ejection fraction right now around more than 50%. So he's doing.
When the patient coded, what rhythm was it?
Actually, that time a patient developed sinus bradycardia. Significant sinus bradycardia, and they have given the atropine at that period of moment. I am just about to the patient, and patient developed sinus tachycardia, severe, and at the same time flash pulmonary edema. So we intubated.
So a couple of things, Shovik bhai.
Yes.
Post procedure cardiac arrest, if it is VFib or sustained VT, polymorphic VT, all of these patient goes back to the cath lab. I have this rule that no compromise, not one, and except somebody can tell me that there is a severe acidosis hyperkalemia, but usually they don't go into VFib, they go into PEA. So VFib arrest is a huge deal following the post-PCI situation. The second thing is that often they are in compromised LV function, and then we give dye, and end diastolic pressure goes up, they go to the floor, they go into flash pulmonary edema. You may have a little MR that may worsen, and then hypoxia and pulmonary edema all lead to a bradycardia. And COVID time, we know how significant the correlation with the hypoxia and bradycardia. And then third issue is that elderly patient, little late presentation, and the PE arrest could be hypoxia, could be hyperkalemia, could be tamponade. So I usually do a bedside echo as well if we have the suspicion post cardiac arrest that resuscitate and then get a quick reassessment of this. But the way the rhythm came back sinus, this is probably all metabolic looks like, because if it is something mechanical or problematic, it doesn't come back that quick. And the other thing is that the De Winter sign or the Wallen sign, these are very characteristic of proximal ostial LAD. So any time in doubt, then I say check it out.
But after resuscitation, we did the ECG and that was fine.
Okay, Dr. Shafiq.
Yes, sir.
Why did the patient become bradycardic?
Actually, sir, that time I was not there, and they just told me patient developed bradycardia, and they have given atropine. After that, patient's heart rate was around 140, 150, something like that. And that time I was there. And
yeah, but our audience would like to know what happened, right?
Actually,
what will be our answer to
number one, sir, patient die could be the reason, and at the same time, inferior myocardial infarction was there.
Okay, sure. So I will come up with a very simple explanation. Just a vagal event, right? Became sinus bradycardia. That's a possibility, right?
Right, sir. Definitely. Sir.
Yes.
This is a simple thing.
I mean, actually, a very interesting case, because I think we should go quick thinking. First, post-procedure, somebody became vagal because of the pain. So that's why the atropine comes into play. Second thing will come into play, did the patient develop pericardial effusion? If it is persistent hypotension, get an echo. And the third will be if patient had VF or something, as Hafiz said, take the patient back to the cath lab. So Very simple. Good case. I would like to have this ECGs with the angiogram, please. These are good cases. And this is a perfect
Rafiq
example.
bhai, one thing I wanted to mention, if I may, vagal in the cath lab and post procedure is not uncommon, but few things with the vagal. One, that there is bradycardia, hypotension, or there is some nausea, vomiting, or something. But vagal giving to cardiac arrest is almost non-existent.
Yeah.
But this patient did not go into cardiac arrest.
Right. Actually, only the bradycardia was there, and then given atropine, and patient
Yes.
developed failure
But
because of the
we
high
never lost
rate.
pulses.
No pulse loss. Yes.
Okay.
Right?
But never lost pulses, right, Shafiq bhai?
Right. Never lost pulses. Pulses were there.
I asked one thing about the procedural strategy. So could the LED
Right.
can be done first, as because that was more acute than the LCA?
Actually, approach could be difficult because I'm going to put the stent from LED to left main. That is why I put LCX first.
Then you have to put the stent through the stars of
Through the
the
stars, yes.
left main stent. So he put it rightly. in the
That is
circumflex
possible,
first.
but
That's fast. Now, your strategy is, I
Right.
think, appropriate.
And I would say that I would very strongly support Shafiq bhai's strategy. And probably is a teaching thing. If you are touching left main and occluding, then secure as much as you can. Secure your RCA, secure other territories, secure other things before you occlude the left main.
right.
So patient will tolerate, particularly if you are doing this without any mechanical support, which you did. Fantastic case.
Thank you.
Next, please. Please continue.
Okay. Female 65 years. 65 years, diabetes, hypertension, CKD, or maintenance hemodialysis, developed cardiac arrest in dialysis ward before dialysis started. Code blue was called and patient was resuscitated and ECG was done. What could be the cause of this rhythm? This is
Just for the
definitely
audience,
agonal rhythm.
this is not pulse oximetry. This is EKG, right?
EKG, right.
Yes.
When the EKG looks like pulse ox, then there is only one diagnosis.
Hyperkalemia.
Yeah.
So, agonal rhythm due to acute myocardial infarction, idioventricular rhythm due to acute myocardial infarction, idioventricular rhythm due to severe hyperkalemia, agonal rhythm due to severe hyperkalemia. Poll, please.
I actually like the answers.
All these diseases are within the last 1 month.
There's no E.
Actually, two idioventricular rhythm due to severe hyperkalemia or agonal rhythm due to severe hyperkalemia. Most are within agonal rhythm due to severe hyperkalemia. So C and D. And most C, maximum D. Sir. So it's not that much difficult. Actually, this is definitely agonal rhythm. And whether severe hyperkalemia or myocardial infarction, that is a question mark.
What is agonal rhythm?
Yes, anybody?
Shafiq, the question
Mamunur
somebody was
Rahman.
asking, what is the agonal rhythm?
Actually, this is end of life rhythm that happened in from many causes. That is at the end of life, the ECG, the busier QRS complex with significant bradycardia sometimes usually rate is less than 20. And this is a busier wide QRS complex. Sometimes QRS complex cannot be distinguished properly, and this is end of life ECG. That is agonal rhythm. So it could be because of myocardial infarction, because of at the end of dilated cardiomyopathy, or even hyperkalemia, or anything else. So can I get any expert opinion, sir?
Can we see the EKG, because it is the answers are in the middle? So
Can you go back, please?
Can we remove the answers?
Right.
So, I mean, we always talk about multiple choice question. In United States board exam, this same question will be half page with lot of things, and there will be giveaways, and giveaway is dialysis. And before.
Yes.
Here.
Yes.
That's the giveaway of this patient. And so the other part, this term agonal rhythm, of course, we use it. It's a vaguely defined term. Most of the time we use it for cases where there is no blood pressure and patient basically is dying. I mean, it's a ventricular escape rhythm. But if you look at this rhythm, it's fairly regular. And it is difficult to say whether it's idioventricular rhythm or a sinus P wave which we just cannot see in the setting. But as Hafiz said, if the ECG looks like pulse oximeter, that actually is hyperkalemia, especially in this context. So this is a diagnosis of hyperkalemia. The rhythm, I cannot tell whether it's coming from the ventricle or there is a sinus P wave that we cannot see, which conducted to the wide QRS. So definitely hyperkalemia. What is the potassium?
Right, sir.
Can I make a comment? One thing is that we know that hyperkalemia suppresses the P waves, and in hypokalemia, the rhythm usually is a VT or VF. So Brady is more likely to be associated with hyperkalemia when the patient has a CKD and before the dialysis.
Right. And history is very suggestive. This is hyperkalemia, and actually patient potassium level was 9.25.
Yeah.
The patient was resuscitated well, and patient survived. Patient intubated initially and then extubated after getting the dialysis.
Now, what is this rhythm?
It is afterwards when the still at this ECG level, patient's potassium level was 7 plus.
Still, we do not see any P wave.
Still, the potassium level was 7. This same patient after resuscitation and after giving the appropriate treatment and starting the dialysis immediately after, potassium level is still 7. Then the ECG was. I did not take the ECG later on, and this is the ECG.
My question to Rafiq Bhai. Can I ask a question to Rafiq Bhai? The lead 3, there is a QRS, and at the end of QRS, there is something like, looks like P wave. You buy that P wave?
Interval prolonged.
I was about to come to that, but go to lead V2. Before there is a P wave in the lead that you are pointing. It can be T or bifid T or U wave or a P, but in V2 it's a little better. You can see the P wave. After the P wave ends, tiny, and it actually superimposes as the rate gets faster, but as the rate gets slower, it moves away. So there is a P wave with marked first degree AV block now.
Right.
Because I think people will say right bundle and left axis, but the QRS morphology and the T wave, I would still say that I would not let anyone pass unless says hyperkalemia. Still, you should be able to read hyperkalemia in this EKG also.
Yes, no question. I mean, it is so important to recognize it because the treatment you can give a lot of things acutely if you have the diagnosis in mind.
Right. And the answer should be in the brainstem, not in cerebral cortex.
I feel very proud about myself and the group that Hafiz is now thinking like an EP doctor.
So, Rovik bhai, just to let you know, our EP conference is every week on Tuesday morning. That's the only conference I drink coffee and enjoy this session, because I have an EP guy presiding over, so I have no pressure. So I enjoy that session most.
Good, ECG. Thank you.
Thank you. Next patient, sir. Maybe it is common to others, sir. Male, 58 years, hypertension, non-diabetic, admitted in our CC with chest pain, palpitation, tropoid positive. ECG, first ECG was atrial fibrillation with first ventricular arrest. Amiodarm was given, and then the ECG is. Then, is it supraventricular rhythm with LVS with strain, supraventricular rhythm with anterior myocardial ischemia, sinus rhythm with LVS with strain, sinus rhythm with WPW syndrome with LVS with strain, or sinus rhythm with WPW syndrome with anterior myocardial ischemia? Can I get the poll, please?
Can you, I think the audience will have difficult time because they cannot see the ECG now.
Okay, sir. Then I can go to ECG again. This is the ECG.
Keep it like this.
It would have been better if the question was beside the picture.
Can I go to question, please?
Answer.
Answer. Oh, already been it is answered.
Can you show the answers?
Right. Can I get the result, please? Can I get the result, please, Ribu?
This is the result.
But the result has been shown.
Oh, I can't see it. Okay.
Majority said C.
Sinus rhythm with LVS with strain. So majority. Right. So this ECG was done in a standard way, that is 10 millimeter per volt.
Shafik, remove the questions. Okay. Go ahead. Shafik.
Shafi?
Yes, sir.
Yeah.
So, can we go for discussion, sir, from panel of experts? Right.
I think most of the participants went right. Though there is peer interval seems to be shorter, but there is no definite delta wave here, and QRS complex is not widened.
Okay.
This may be LGL, like ECG.
Right. Okay, we are going to next ECG.
Can you come back?
So, ECG done. Okay, sir.
Okay. So I think as Jamil mentioned that PR is short, but look at lead 2. You can see in the delta wave, the P wave will not end and the KYS will start. Right. But that is not the case. And it is more clear in lead V1. So it's a short PR, but not per se typical WPW syndrome.
Yes, sir.
That's important. I think the other part is bothering me is I think there is early transition, whether the leads were placed right in lead V2, V3. So keep that in mind, but that doesn't affect because V6 is great. V5, V6 is a good looking ECG. Yes. So when you interpret this ECG, you have to keep in mind that lead V2, V3 transition is early maybe lead malposition, but V1 definitely is in the right place because P wave is biphasic, small RS, and the V6 and V5 and V6 are in right place. So that will give us enough material to interpret this ECG. Okay, go. Let's go to the next one.
Shafiq, can you show us the answers? The question is, if you have WPW, can you diagnose LVH or can you diagnose ischemia in presence of WPW?
Difficult to.
And so that is why I have some differentials. LVAs, yes, whether we can diagnose LVAs.
Would you please give us some clue about that? Because traditionally we tell the students that when you have WPW, you should not put the diagnosis of LVH or the enteroischemia or something like that.
Yeah, you were right, because what happens, same as a PVC. I cannot diagnose LVH from a PVC. Let's say if I have a ventricular tachycardia ECG, I cannot diagnose LVH. And a pre-excited QRS complex will basically, it's a ventricular aberrant conduction through the accessory. So that becomes, I think we should keep that off our mind and just say WPW syndrome. Thank you.
Okay, sir. Thank you, sir. Actually, we did the ECG later on with
now it's classical
5 millimeter per millivolt. So right now, this looks like WPW syndrome. Delta wave is there.
Yeah, if you look at V3, there is initial slurring.
Yes, sir. And V4 as well, sir.
Did you confirm this diagnosis?
Sir, it has already been ablated.
Is it pre-ablation or post-ablation?
Sir, actually, Athar sir already ablated the case. Actually, this patient admitted in our hospital. Then I sent the patient, and patient as well as this is the EKG of atrial fibrillation when admitted first time with this ECG, and patient was given amiodarone. Later on, we got the ECG first, and we did the angiogram as well, sir, because patient having troponin positive more than 2,000 probably. And
where is the pathway?
Sir, actually, this case was sent to me by Dr.S.M. Shafiq, and I was also interested about this case as because this patient has got the hypertrophic cardiomyopathy.
Yes, sir. Hypertrophic obstructive type.
And this ECG and this atrial fibrillation, and the patient has got the frequent symptoms of palpitation. So on academic interest, actually, I did the electrophysiology study. The patient had got the typical supraventricular left lateral pathway, sir. Left lateral pathway, and had successfully ablated it.
So look at lead V4. If you see the QRS, now there is a variability of the QRS duration during AFib.
Yes, sir.
Especially 1, 2, 3, 4, 5. Number 6 complex is narrow. And then number 7 is wide. And that fits in with WPW. So it's a subtle pre-excitation, very nice ECG.
So the first ECG was recorded after ablation?
No. That was
first ECG actually after amiodarone, patient reverted to this ECG. And actually the QRS complexes are not good. That is why we did low voltage, that is 5 millimeter per millivolt. Then we could see the WPW pattern.
I will show the ECG before and after ablation in next another session. Actually, I have got this. Yes.
Good.
Okay, thank you, sir.
Could it be intermittently manifested? When the first ECG was recorded, it was less manifested. Now it is more manifested.
Actually, fast ECG, it is really difficult to understand. Still, there is a pre-excitation. ECG is there. Here,
okay. Let me make a comment on this.
Right.
What happened? This ECG was done after patient converted to sinus rhythm, right?
Right, sir. Right, sir.
That means, and the patient had amiodarone.
Right, sir.
Right, sir.
So that affected the accessory pathway conduction. And that's why the ECG looks more really confusing. Right. I think that is the only explanation that I can come up with, that the accessory pathway was blocked by the amiodarone and conduction mainly happened through the
Normal system.
normal pathway.
This
Thank you.
beautiful cases, Shafiq.
Thank you, sir.
Yeah, very true.
And patient's resting LVOT gradient was 59 millimeters. And we did the angiogram as well, and it was normal.
So long-term management-wise, I have a question. Will you consider anticoagulation for this patient?
Even after ablation of the WPW pathway?
So that's the question I'm asking. So atrial fibrillation, WPW syndrome itself cannot provoke, whether it can provoke atrial fibrillation. If it is, then, but patient might have atrial fibrillation because of hypertrophic cardiomyopathy, ALA dilated. In that case, patient might need anticoagulation lifelong.
Yes.
So one of the issue, hypertrophic cardiomyopathy, then you ignore chats to VASCOR because they are notorious for stroke risk and they are young. But as Wadud mentioned, this patient had WPW syndrome. So that will create a little dilemma for us. And WPW syndrome patients, if they have AFib after ablation of accessory pathway, they may not have recurrence of atrial fibrillation at all. And if we can prove that, then he may not need anticoagulation long term. And probably this is related to WPW syndrome, the AFib issue in this patient.
Sir, in that case, you should give the anticoagulant for 6 months and follow up, sir.
Well, that's what probably I will do. I'll give short-term anticoagulation and then do a halter or some kind of monitoring just to make sure that the patient is not having AFib. And the other part is that this patient had palpitation. That's a good thing because a lot of patients cannot feel AFib. So this patient will be able to tell if they're going to AFib. So one will be getting a couple of Holter monitors and then ask the patient, look, if you have palpitation, just let us know.
Sir.
Thank you.
Sir.
Yeah.
Rufik sir.
Yes.
But the substrate of hypertrophic cardiomyopathy is still there. It will be there. So for this patient, considering anticoagulation for long time wouldn't be a much rational approach.
Okay.
Because the HCM is there.
Absolutely.
We are not curing that thing.
Yes. So let's put a scenario, a different scenario. Somebody has diabetes, hypertension, and vascular disease. Charles VAS score is 3 now. Without AFib, we don't anticoagulate them. We only anticoagulate when there is AFib. So the question is coming up that was the AFib as part of hypertrophic cardiomyopathy or was the AFib due to WPW? That's where the discussion is coming up. Yes. And a 58-year-old subjecting him to a long-term anticoagulation for many, many years. If necessary, we'll give it, but if we can avoid it, it will be good. But your point is well taken. Until we can prove it definitively, then we should anticoagulate the patient until we make a conclusion. Look, what we will do here, I'm going to put a loop recorder in this patient. I'll continue anticoagulation 6 months to a year, no AFib, I'll stop. And then I'll continue monitoring this patient with the loop recorder for another 3 years because the loop recorder will last 4 years. And let's say if there is no AFib, then I'll say, look, you don't have any AFib, so you don't need it. And after 6 months, I stop the anticoagulation. If there is any AFib in future, then I'll restart it for lifelong. Thank you.
That's very reasonable.
Thank you, sir.
I think it's 12 o'clock. Do you want to continue or you want to stop here?
No.
You can stop, sir. Shobhik.
Yes.
We really enjoyed it.
Yeah, I think you have got some more cases and very interesting cases, nicely presented. I want to discuss. Can you keep it for the next session?
I think we need to get another session for Dr. Shafiq.
Right,
these are good ECGs, provocative cases, and this is the beauty of it, that showing ECG from your practice, patients that you have taken care of, and that touches us, all of us, and that's the beauty of it, and that's the real life scenario. This patient came, went to the cath lab, became bradycardic. We are not talking about any hypothetical situation. We will discuss theory True, patient could have VA, patient could have pericardial, but we found out that most probably this was vasovagal because a patient became bradycardic, a little dizzy, and atropine responded. That proves my diagnosis. That's what we need to see. Thank you. Hafiz has actually a lecture on troponin, and there is a site, I don't know if you got the link. He's talking about troponin elevation and definition of MI, which is a very interesting topic, I find. So I'm going to attend that now. So thank you all.
Sir, before that, on behalf of ECG study group, we want to congratulate Dr. Chaudhary Hafiz. Actually, he is rewarded fellowship from the BCPS. Abdullah Chaudhary.
Sir, it's really something that we really feel proud of. And when we are talking about actually the giving of the fellowship, we just followed, Rafiq sir got it last year, isn't it, sir?
2013.
2013, last time. And this time we think about in cardiology who should be nominated. And the name came out, the name that came out is Chaudhary Rahiduzzaman. We really feel proud from the ECG study group that we are associated with him and he is contributing so much in our forum. And we, as Bangladeshi doctors who are residing in abroad, and they're contributing in such a way for advancement of our doctors who are residing here, this মেলবন্ধন আমি যেটা বলবো এটা অসাধারণ। সেই জন্য বিসিপিএস এর পক্ষ থেকে ইউনানিমাস সবার সিদ্ধান্ত এলো যে তাদেরকে আমরা ফেলোশিপ কনফার্ম করলে আমরা সম্মানিত হব, সেটাই স্যার।
Thank you. So I was the first one who was given. Hafiz is the second Bangladeshi outside of Bangladesh.
Yes,
and
sir.
I'm very proud of Hafiz because of his continued contribution. I mean, it says, you know, there are two ways to serve. One is serve when you are asked. Our motto is we serve because we have to serve. And Hafiz have followed that. It is our obligation. It is our duty, and we will continue it as long as we can. And also, I thank you all on behalf of Hafiz is not here, that for such an honor, and hopefully we can live up to this. Thank you.
Thank you, sir.
Thank you, sir.
Swadesh.
Thank you, sir.
Thank you very much for your
Thank you,
excellent
bhai.
presentation. Really. তুমি অনেক পরিশ্রম করে প্রেজেন্টেশন করছে, তোমার এটা রিভিউ আকারে পাবলিশ করতে হবে। দিস ইজ এ ভেরি রিয়ার, মানে অ্যাকচুয়ালি মানে ডিফিকাল্ট টপিক, মেড ইট ইজি স্বদেশ। আর আমার মনে হয় যে এম শফিক,
Yes, sir.
you can keep your presentation every day ready, like Rafiq sir and Hafiz sir. You can keep every day ready.